ACE inhibitors block the angiotensin converting enzyme, the enzyme that converts angiotensin 1 to angiotensin 2, the active form, using up bradykinin in the process. But what if we could just block the angiotensin 2? Wouldn't that stop the buildup of bradykinin, avoiding all the side effects that come with it? Well, that's what we do with angiotensin receptor blockers, or ARBs for short. ARBs can still offer some of the great benefits that we see with ACE inhibitors, along with some other benefits that were totally unexpected that came from post-marketing studies. So this video is going to talk a little bit more about them. Let's get going. So ARBs are very similar to ACE inhibitors in a lot of ways. They have really good benefits for the health of the kidneys by reducing pressure inside the kidney. They help with the blood pressure alongside other blood pressure lowering medicines, and they feature really highly in hypertension guidance. There are a few really important differences though. The first of these is the evidence base for the use in heart failure is not as strong as ACE inhibitors. In fact, only one of them has a really good study backing this up, and that's Candesartan. I would say that I would still recommend using these in patients who are intolerant of an ACE inhibitor who have heart failure, and would probably aim to use Candesartan first out of all of the ones that are available. Thankfully, most of the other differences are advantages more than anything else. They can really help your patients if they're struggling with multiple comorbidities, to trim down the medicine list, and make things simpler overall. So let's have a look at these. First, there's evidence that Candesartan can help with migraine prophylaxis by reducing the intensity and severity of attacks. Whilst the evidence base isn't as strong as we have for amitriptyline or propranolol, this can be a really useful option if we're struggling to get someone's migraines under control. Remember, the evidence of benefit starts at 16 milligrams a day, so it's really important that we titrate up to this dose if at all possible. Second, there's evidence that losartan helps to reduce the frequency of gout attacks. It does this by helping the body clear out uric acid. Whilst this effect is mild, it usually will reduce uric acid levels by about 25%. When this is combined with lifestyle interventions, this can often eliminate the need for other gout preventing treatments like allopurinol or febuxostat. So have a go. Third, another ARB called Telmisartan actually can help with diabetes by reducing insulin resistance. It does this effect by partially activating the PPAR-gamma pathway. That's the same pathway that's used by full agonists like pioglitazone. Now, drugs like pioglitazone have started to fall out of favour in diabetes management due to negative effects on the heart and weight gain. But there's evidence that partial agonists might avoid some of these effects by not activating those parts of the PPAR-gamma pathway. I've added links in the video description to all the papers that back up these effects, so feel free to check them out when you get a chance. Out of the available ARBs, I would recommend sticking to a cost-effective one. For example, Candesartan or losartan, and getting to know how this works and the effects that we'll expect to see in your patients. I personally start the majority of my patients on Candesartan due to the better evidence base for heart failure. Remember, whichever one you choose, it's really important that you arrange the blood monitoring, and it's exactly the same monitoring as we had for ACE inhibitors. So make sure you always check the UNEs and the blood pressure after starting and before any other dose increases. So there you have it. You can now confidently utilise these lesser known benefits of this class of medicines. Tune in for the next video where I'll be covering something totally different but I get asked about all the time: knee pain. See you then.